Here is something medical school teaches surgeons, but nobody teaches patients. A technically successful surgery and a good outcome for the patient are not the same thing. Read that again, because it matters more than almost anything else I'm going to tell you today. A surgeon can do everything right: perfect incision, clean repair, textbook procedure from start to finish. The operation is a success by every clinical measure, and the patient can still leave that hospital in worse shape than they arrived: weaker, more confused, less independent, sometimes permanently. I've watched it happen more times than I care to count, and every single time the same thought runs through my mind. Did anyone ask the right questions before this? My name is Dr. Marcus Adebayo. I'm a physician and cardiologist. I've spent decades working with patients navigating the most consequential decisions of their medical lives. Today I want to give you something the system rarely offers. Not a diagnosis, not a prescription, just the truth about 5 surgeries that carry hidden risks for Americans over 60, what those risks actually look like, and what questions you need to ask before anyone picks up a scalpel with your name on the schedule. Because you deserve more than a brochure. You deserve a real conversation, and that conversation starts right now. Let me describe something that happens in American medicine every single day. A patient sees their primary care doctor about a symptom: shortness of breath, joint pain, an abnormal scan result. The primary care doctor refers them to a specialist. The specialist orders more tests. The test shows something. The specialist refers them to a surgeon. The surgeon says, "We should operate." At no point in that entire chain did anyone stop and ask, should we operate on this patient? Not the average patient, not the textbook case, this specific human being. That is what I call surgical momentum. The system builds speed as it goes. Each referral feels like progress. Each appointment feels like moving toward a solution. By the time a patient is sitting across from a surgeon, the psychological current pulling them toward the operating room can be almost impossible to resist. I am not describing negligence. I am describing a system designed around disease, not around the whole person carrying that disease. And for patients over 60, that distinction can make an enormous difference. Here is the biology. After 60, the body's inflammatory response to surgical trauma changes fundamentally. A younger body mounts an inflammatory response after surgery, does its work, and shuts it down within days. An older body mounts the same response, but has significantly more difficulty shutting it off. That persistent inflammation after major surgery is now linked to accelerated cognitive decline, prolonged fatigue, and weakened immune function, and what researchers call post-operative deconditioning, a spiral where limited mobility leads to muscle loss, which leads to further weakness, which extends recovery, which increases risk of pneumonia and blood clots. This is not inevitable. It is not a reason to avoid all surgery, but it is a serious science-backed reason to look carefully at whether a procedure offers enough benefit to justify that biological cost. And that careful look is exactly what the 5 procedures I'm about to describe demand. Procedure number 1, pacemaker implantation in end-stage heart failure. And I want to start with this one because it surprises people the most. When most Americans hear pacemaker, they think small device, routine procedure, quick recovery. And for many patients, that description is accurate. Pacemakers have transformed cardiac care and given millions additional years of quality life. But there is a specific situation where that picture breaks down completely. Patients already in end-stage heart failure, where muscle damage is so severe and irreversible that no electrical intervention can change the trajectory. A pacemaker regulates the electrical rhythm of the heart. What it cannot do, what no device can do, is restore muscle destroyed by years of disease. If the underlying pump is failing at a fundamental level, making it beat more regularly does not make it beat more effectively. That single fact changes everything about whether this procedure makes sense. In patients over 70 with end-stage heart failure and ejection fractions below 25%, pacemaker implantation carries risks including cardiac perforation, lead displacement, device infection, and cardiac tamponade. Multiple studies show that in patients with severely reduced cardiac function and multiple organ involvement, device therapy does not reliably extend meaningful life. What it sometimes does instead is extend the dying process, which is a profoundly different thing, and a distinction that deserves to be spoken out loud before any consent form is signed. This conversation needs to go much deeper than "your rhythm is abnormal, let's fix it." It needs a direct, honest discussion about goals of care. What does quality of life mean to this person? Has your cardiologist ever discussed goals of care with you directly? Not just treatment options, but what you actually want your life to look like. Write that in the comments. I read every one. Procedure number 2, carotid artery surgery in low symptom patients. This one is less well known than the others, and that's exactly why it needs to be on this list. The carotid arteries run up either side of your neck, supplying blood to your brain. When imaging shows significant plaque buildup, the concern is that a piece could break off and cause a stroke. The surgical response, carotid endarterectomy, opens the artery, physically removes the plaque, and closes the vessel. In patients who have already had symptoms, the evidence for this surgery is reasonably strong, but a significant number of carotid surgeries in the United States are performed on patients who have no symptoms at all. Their stenosis was found incidentally, on an ultrasound done for another reason entirely. They feel fine. They have had no neurological events, and yet they are referred for surgery on the basis of the imaging alone. That referral pattern deserves serious scrutiny. For asymptomatic carotid stenosis, annual stroke risk on medical therapy is 1 to 2% per year. Surgical risk in elderly patients runs 2 to 5%. The numbers deserve comparison. For some elderly patients with asymptomatic carotid stenosis, the surgery itself carries a higher immediate risk of the stroke it is meant to prevent than the plaque does over the same time period. This does not mean never operate. It means the threshold for operating on an asymptomatic elderly patient needs to be extraordinarily high. The conversation must include an honest comparison of surgical risk versus medical management with statins, blood pressure control, and antiplatelet therapy. Ask your surgeon to put both numbers on the table. Any vascular surgeon worth their credentials will walk you through that comparison honestly, and the answer might surprise you. Procedure number 3, aggressive lung resection in elderly smokers. Let me tell you about a conversation that changed how I think about this procedure entirely. A patient, I'll call him Raymond, 74 years old, retired postal worker from Alabama, lifelong smoker, quit 8 years earlier. A routine chest scan found a small tumor in his right lung. His pulmonologist referred him to a thoracic surgeon. The surgeon recommended lobectomy, removal of an entire lobe of the lung. Raymond was ready to say yes on the spot, because when someone tells you there's something in your lung that shouldn't be there, every instinct says, get it out. I understand that completely. But I asked Raymond one question before he scheduled anything. Has anyone tested your pulmonary function? He looked at me blankly. Nobody had. And that gap, right there, was the most important medical fact in the room. Here's why that question matters so much. Lung resection permanently reduces your breathing capacity. In a healthy 45-year-old, that reduction is manageable. The remaining lung tissue compensates over time. In a 74-year-old lifelong smoker, remaining lung tissue is already compromised. Emphysema, reduced elasticity. Removing a lobe from lungs already below capacity can leave someone unable to climb stairs for life. Pulmonary function testing, specifically a measurement called FEV1, measures how much air you can forcefully exhale in 1 second. It predicts post-surgical breathing capacity with remarkable accuracy. Patients with pre-surgical FEV1 below 50% of predicted normal have dramatically elevated risks of respiratory failure, prolonged ventilator dependence, and what thoracic surgeons call respiratory crippling after major lung resection. Raymond's FEV1 came back at 43%. His surgeon, when presented with that number, agreed that lobectomy carried unacceptable risk for Raymond's specific lung function. Instead, Raymond was referred for stereotactic body radiation therapy, a highly targeted radiation approach that destroys tumor tissue with precision while leaving the surrounding lung intact. No incision, no general anesthesia, outpatient treatment. Raymond completed his radiation course 8 months ago. His tumor is gone, and he still walks his dog every evening without supplemental oxygen. Before any lung surgery, ask, has my FEV1 been tested, and what does it predict about my breathing capacity afterward? If that test hasn't been ordered, request it before you agree to anything. Procedure number 4, total hip replacement in patients with dementia. This is perhaps the most emotionally difficult on this list. Total hip replacement is a remarkable surgical achievement for the right patient, but the clinical reality that doesn't reach families. Recovery requires something dementia patients fundamentally struggle to provide. Post-operative recovery from hip replacement requires consistent cooperation with precise rehabilitation restrictions. Patients with moderate to severe dementia fundamentally cannot provide this reliably, and the consequences are serious. Recovery depends on following movement restrictions exactly. No hip bending past 90 degrees, no crossed legs. Walker used precisely as instructed. These rules prevent dislocation, and a patient with dementia cannot reliably remember them. A patient with moderate dementia cannot reliably remember these instructions from 1 hour to the next, and the consequences of non-compliance in the first 6 weeks after hip replacement are serious. Dislocation rates in cognitively impaired elderly patients run 2 to 3 times higher than in cognitively intact patients of the same age. And a dislocation often means emergency revision surgery, under anesthesia again. Beyond dislocation, the post-operative delirium that follows major surgery is significantly more severe and more prolonged in patients with existing cognitive impairment. What presents as temporary confusion in a healthy patient can become weeks of profound disorientation in a patient with dementia, accelerating cognitive decline that may never fully reverse. Mild cognitive impairment is not a blanket reason to deny hip replacement. Some patients with early cognitive changes do well with the right support structure. The question is whether that support structure realistically exists. Before hip replacement in any patient with known cognitive impairment, ask for a formal cognitive assessment using a standardized tool. Ask specifically what the surgeon's experience is with cognitively impaired patients. Ask honestly, who will manage rehabilitation restrictions at home, and are they fully prepared for what that involves? Those 3 questions alone determine whether surgery is right at this moment, or whether pain management, physical therapy, and home modifications might serve this patient better without the surgical risk. Procedure number 5, dialysis access surgery in terminal kidney patients. I need to speak carefully here, because this procedure sits where medicine, mortality, and human dignity intersect. When the kidneys fail permanently, dialysis becomes necessary to filter the blood artificially. And to perform dialysis, doctors need reliable access to the bloodstream through a procedure that creates what's called an arteriovenous fistula. For patients with meaningful life ahead, years of living, relationships, purpose, dialysis access surgery is a gateway to continued life. I fully support it in the right context, but elderly patients with end-stage kidney disease and profound frailty are sometimes referred for dialysis access as an automatic step, without an honest conversation about what dialysis at that stage actually means. Dialysis in an elderly, frail patient is not a gentle procedure. 3 sessions per week, each lasting 3 to 4 hours, connected to a machine that filters blood under significant physiological stress. The sessions are exhausting. They frequently cause low blood pressure, cramping, nausea, and profound fatigue that can persist for the entire day following each session. For a patient already frail, already fatigued, already managing multiple serious conditions, dialysis can consume the remaining quality of whatever time they have. A landmark study in the Journal of the American Society of Nephrology found that among nursing home patients over 75 who began dialysis, median survival was just under a year. And during that year, the majority spent a significant portion of their remaining time either on dialysis or recovering from it. That data deserves to be part of the conversation. What does a good day look like to them? What are they willing to go through? And what aren't they? Human questions. They deserve honest answers before a consent form appears. These are not medical questions, they are human ones. And they deserve as much honesty and time as any clinical decision being made in that room. Let me come back now to something I mentioned at the beginning, surgical momentum. Because understanding exactly how it works is one of the most protective things I can give you today. Your doctor finds something on a scan. He looks concerned. You feel scared. He refers you to a specialist, and that referral feels like action, like forward movement, like someone taking your problem seriously. The specialist orders more tests. The tests show something. Now there is objective evidence of a problem. You have been through 3 appointments, multiple tests, weeks of waiting and worrying. You are emotionally invested. And then the surgeon says, I think we should operate. And somewhere in your mind, the momentum of everything that has led to this moment makes saying yes feel almost inevitable. Saying no feels like going backward, like giving up, like wasting everything you've been through. That feeling is human, and it is one of the most dangerous places a medical decision can come from. The antidote to surgical momentum is not distrust. It is not refusing every procedure. It is simply this: a deliberate pause. A moment where you step outside the current and ask, if I were coming to this decision fresh, with no history of appointments and tests behind me, would I still say yes? That pause is free. It costs nothing but a day or two. And in my experience, patients who take it make significantly better surgical decisions than those who don't. Before I get to the most important part of today, I want to give you something concrete. 3 conversations that can change everything before any major surgical decision. Not questions, not checklists, conversations. Because the difference between a question and a conversation is that a conversation requires the other person to fully engage. And full engagement from your medical team is exactly what you deserve. So here are the 3 conversations that matter most. Conversation 1 is with your surgeon, about your specific body, not the average patient. Given my age, my existing conditions, my current functional level, what does recovery realistically look like for me personally? Not the textbook case, not the clinical average. You. A surgeon who knows their patient will answer that specifically. Push for specifics if you get generalities. Conversation 2 is with your primary care physician, and it is about alternatives. Is surgery the only path, or are there non-surgical approaches with meaningful evidence behind them for someone with my health profile? Your primary care doctor has a perspective your surgeon may not, because they see your whole picture, not just the surgical target. Use that perspective. It belongs in your decision. Conversation 3 is with yourself, or someone who loves you. What do I actually want? Not what I fear, not what my doctor prefers. What do I want from this? That conversation is not medical, but it shapes every medical decision that follows, and it deserves as much time and honesty as you can give it. Have you ever pushed back on a surgical recommendation and asked for an alternative? What happened? Every story shared here helps someone else find the courage to ask the right question at the right moment. I want to tell you about a patient named Walter, 79 years old, retired high school football coach from Mississippi, built like he still coached, broad shoulders, firm handshake. Walter came to me after his cardiologist referred him for carotid surgery. 75% blockage, no symptoms, no mini strokes, no vision changes, just a number on an ultrasound that set the whole chain in motion. By the time Walter sat across from me, he had met the vascular surgeon twice. Blood work done. His wife had arranged for her sister to come during recovery. The momentum was completely built. Walter told me, and I remember this exactly, "Doc, I guess we're doing this. I guess we're doing this." Those 5 words stopped me cold, because they weren't the words of a man who had made a decision. They were the words of a man who had been carried to one. I asked Walter to hold everything for 48 hours. We sat together for nearly an hour, something that never happens in modern medicine. We went through his numbers carefully. His annual stroke risk on optimized medical therapy, statins, blood pressure control, antiplatelet medication was approximately 1.4% per year. His procedural risk ran between 2.8 and 3.5%, more than twice the risk of the condition it was meant to treat. And nobody had said that until we sat together. Walter's wife cried when I explained it, not from grief, from relief. She said nobody had ever laid it out that plainly before. 3 specialists, 2 surgical consultations, weeks of appointments, and nobody had put those 2 numbers side by side. That is surgical momentum at its most dangerous. Walter did not have surgery. He went on optimized medical management. I see him every 6 months. His stenosis has not progressed significantly. His neurological function is intact. Last spring, he flew to New Orleans to watch his grandson play college football. He sent me a picture from the stadium. I have it on my phone to this day. Here is what I need you to understand. This is the most important thing I will say today. The system is not designed to slow down for you. Not designed to sit with you for an hour. Not designed to ask what you want your life to look like after this decision. Those things happen when individual doctors choose to prioritize them, and when individual patients know enough to demand them. That knowledge is what I'm trying to give you today. You are not obligated to be swept along by surgical momentum, not obligated to sign anything the day it is handed to you, not obligated to be grateful in a way that silences your questions. The most dangerous moment in medicine, and I have believed this for 30 years, is when a patient feels too grateful or too overwhelmed to ask the question that could change everything. What is that question? It is the simplest one in the room. Do I actually need this? And what happens if I don't do it right now? That question has saved more lives than I can count, and it belongs in your vocabulary starting today. Let's land this together, because we covered serious ground today, and I want to make sure the right things stay with you. 5 procedures that demand a harder look before any American over 60 says yes. Pacemaker implantation in end-stage heart failure, where device therapy cannot restore muscle disease has already destroyed, and where goals of care deserve an honest conversation. First, carotid artery surgery in low-symptom patients, where the procedural risk can exceed the annual stroke risk of the condition itself when modern medical therapy is properly applied. Aggressive lung resection in elderly smokers, where pulmonary function testing must happen before any surgical decision because breathing capacity after surgery depends entirely on breathing capacity before it. Total hip replacement in patients with dementia, where cognitive status determines rehabilitation compliance, and where the real question is whether the support structure for recovery actually exists. In dialysis access surgery in terminal kidney patients, where the commitment to dialysis deserves a full human conversation about quality of life, not just a surgical referral. None of this is anti-medicine, none of this is anti-surgeon. I have enormous respect for the people who do this work. What I am is pro-patient. And being pro-patient means making sure the person who has to live with the outcome of a surgical decision is the one driving it. Not the system, not the momentum, that person. So here is what I am asking you to do before any major procedure. Understand your surgical momentum. Recognize when the system is carrying you rather than you carrying yourself. Have the 3 conversations with your surgeon about your specific body, with your primary care doctor about alternatives, and with yourself about what you actually want. And ask the one question that belongs in every surgical consultation in America. Do I actually need this? And what happens if I wait? If this conversation helped you think more clearly about a surgical decision, share this video. That share might be the most courageous medical act someone in your life makes this year. Take care of yourselves. Slow down when the system speeds up. Ask the questions that feel too big to ask. And remember, the most powerful person in any medical conversation is the one who knows what they want and isn't afraid to say it. And one final thing, everything I've shared today is based on published clinical research and my own professional experience as a physician and cardiologist. It is general medical information, not personal medical advice. Your body is unique. Your history is unique. Every surgical decision you face deserves a full, unhurried, honest conversation with the doctors who know your complete picture. Please have that conversation on your terms, at your pace. You have earned that right. One more thing before you go. A single sentence you can carry into any medical appointment, any moment when the momentum starts to build. I need to understand this fully before I decide. 6 words. That's all. Say them calmly. Say them as many times as you need. No good doctor will object. Those 6 words tell your medical team that you are an active participant in your care, not a passive recipient of their decisions. They signal that you expect a real conversation. And in my 30 years of practice, I have never once seen a patient harmed by asking for one. Drop your most important health question in the comments right now. Not just about surgery, anything on your mind about how to navigate the medical system after 60. I will do my best to address what I see there. Because this community, the people who watch, who share, who ask, you are exactly why this work matters. Stay informed, stay curious, and above all, stay in the driver's seat of your own health. Nobody else can do that for you, and nobody else should. Take care of yourselves. I'll see you in the next one.